Oh, so I have a bit of issue with my voice, but I'm sure we'll get through this. I consider it a great privilege to be here. As HR said in his introduction, I was a student of National College from the National Middle School days, class 5 until I entered medical school, Bangalore Medical College, and it gives me very fond memories of my time here, and it's always a pleasure and a privilege to be here. What I would like to talk today is about scientific basis of medical tests. You can look at the scientific basis of any test in two different angles. The first one is, what is the science behind an X-ray? What is the science behind an ultrasound examination? What is the science behind a CT scanner or something like that? But I'm not looking at scientific tests in that angle. I'm looking at it from more of a consumer's point of view, as a patient and as a doctor. How scientifically valid are the tests that we do? How correct are we in applying the results of tests to the kind of treatment that we give? And what is being done in this uncertain world? We all know that the world is uncertain in many ways, particularly in the human body. It is so complex, and our knowledge of what we are doing is actually just scratch the surface. There's a lot of things that we don't know. But in an uncertain situation like that, how are we trying to be scientific and trying to apply principles of science and making some sense out of a complex situation? I start with my respects to Professor Chen, and I think is a great human being, and this movement of Bangalore Science Forum, of which he was one of the architects, is a great thing. In a very complex world like ours, I think the only redeeming thing will be science. If we start looking at various, arbitrary things, making ad hoc decisions and things like that, life becomes even more chaotic. And to bring some science and some order into this chaotic life, I think we should all have a scientific outlook, and at the end of maybe 45 minutes today, we'll probably have some idea of how we look at things. Chen's greatest attempt throughout his life was to improve scientific temper. In fact, all the activity that's going on in Bangalore Science Forum and several other fora is in fact basically to improve the scientific temper of all of us. And basically, a scientific temper is a state of mind. It's an attitude which involves application of logic and avoidance of bias. In fact, that's all we need to know. When we take a decision about doing something, asking for a test, doing an operation, taking a medicine, not taking a medicine, whatever, rather than apply some ad hoc kind of thought process in selecting a given thing, if we make it scientific, and that's all the scientific temper is. But what was to me a relatively recent revelation was that the Indian Constitution mandates that it's a fundamental duty of every Indian citizen to develop a scientific temper. I didn't know that, but I think our forefathers who wrote the constitutions were extremely enlightened. And it actually mentions in the constitution that all of us must have a scientific temper. And what is science? You understand that there is nothing new about science. New developments keep occurring, but science is a very old phenomenon. In 1853, this definition was given by Ruskin. It's a process in which you substitute facts for appearances and demonstrations for impressions. Whenever I talk about, to my students, we train postgraduate surgeons, when we talk to them about writing papers and having a project or doing some kind of scientific work, academic work, this is a standard slide of mine. One of the first two slides in any of my talk on science is this. It's a very old definition, substitution of facts for appearances and demonstrations for impressions. First impression may be something, but then you have to demonstrate and prove that phenomenon is in fact occurring. And one of the basis of everything that is scientific is that the phenomenon must be reproducible. If somebody does it once and says this is it, and if others cannot reproduce it, it is not scientifically valid. And down to medicine and science of medicine, it is very difficult to make medicine scientific because the human body is very complex and several what we call confounding variables act on the body. It's not that you give one medicine, compare A with B and say which one is better depending on the outcome, because there will be 10 other factors influencing the work of these medicines, the action of these medicines. These are about the other factors that we talk about are confounding variables, and it's always very difficult in medicine to account for and take into consideration these confounding variables. And so the endeavor of every doctor, being a surgeon, I'm not talking surgery today, I'm talking like a doctor, not just necessarily a surgeon, is to get the correct treatment. And one of my professors in BMC, Professor Narayan Shetty, physiology professor, drilled it into us when we started medicine, in the first year of medicine, that good medicine means 3 important steps in life. Being a good doctor means you do 3 things correctly in life. And the 3 things are diagnosis, diagnosis, and diagnosis. Not 3 separate things. The point I was making was that if you get your diagnosis right, that everything else falls into place. The treatment, the selection of the same outcome, everything becomes right. But it's a very nice thing to say and a nice thing to understand, but to practice, it is almost impossible. I can tell you after 35 years of work in surgery and medicine in the area, that it is very difficult to be very accurate about diagnosis. And when you think about diagnosing any disease, I give you the example of a working surgeon. Could be sorry about this. So what we are trying to do here is give you the logical sequence of work from any doctor in any disease. The first thing is to get a clinical history, talk to the patient and see what issue is. Then go on to a clinical examination, examine him, and you can examine the patient and see what findings that you get, what we call physical findings. And then we do a lot of tests, because the days when somebody would want somebody's pulse and say, this person is pregnant or something, we see it in cinemas all the time, Nadi Aushdi, Nadi Jyotisha, all those things happen. Those things are really gone now. Clinical examination is very important. I'm not saying it's not important, but the amount of information you can get from clinical examination is limited. And for you to get a real proper examination, you need to corroborate it with investigations. And once you do these tests, then you get a diagnosis and post-treatment follows. And in a large majority of cases, I may say easily about 90% of cases, I'm giving you the example of a cancer in the rectum here. Pretty straightforward procedure. The patient comes to you with some abdominal pain, maybe some rectal bleeding, says passing mucus. Do an examination. You may find some fullness or what we call a mass in the abdomen if it is very advanced, otherwise you may not have anything. Then you do a classic investigation called sigmoidoscopy, which is a part of an endoscopic examination. You put a little tube up the rectum and look inside, and you'll find that this is a normal lining, which is flat with normal blood vessels, but here you can see a growth. There's a lump there, the lump that should not be there. That is a classic cancer. And then what you do is that today the gold standard for diagnosis is tissue diagnosis, what you find on microscopic examination, not just what you see. And so we take a little piece from there, we call it a biopsy, and the biopsy is fixed and then examined under a microscope, and you get a classic picture of a cancer rectum. Once you do that, then there are various other things, investigations tell you staging and things like that, and you start with the treatment. But what happens is that as the diseases have become more and more prominent, no doubt that the incidence or the occurrence of diseases has become more prominent over a period of years. The pattern has changed. People live longer. Well before somebody got a cancer rectum, he would be died of tuberculosis or some infection. The average age was only 45 earlier. Today it is 74. And so if you live longer, you get all these things. So disease pattern has changed, and the way you diagnose it has become changed. And so you have a whole lot of investigations. It's not that you do one test or 3 tests and then you get a diagnosis. It's becoming more and more complex. And you have a whole lot of tests that we have. And the more you have, the more confusing one gets as to how you interpret those tests. And then, different tests give you different kinds of results, and then they don't necessarily corroborate. So the confusion increases. If the confusion increases in the doctor, you can imagine how much more confusing it is for the patient, who expects the doctor to know everything. And this is where the problem is, and the gist of my talk today is to tell you how we try to make some sense out of all this complexity. So you have hematology, which is blood reports that we do, and you have several things. Now I'm just giving you a little peek into the kind of tests that we do. Each one of these will have some 200 tests. But I'm giving you the common ones that you do, that you actually, when you go to a doctor, you will see that all these things are usually listed. Then you have biochemistry, where you have blood sugar, urea, creatinine, and things like that, phosphorus, calcium. There are any number of those, but you use those. You have radiology, which is the X-ray and related investigations like ultrasound, CT scan. You have magnetic resonance imaging called MRI, and another very expensive, fancy thing called PET-CT, positron emission tomography CT. Then you come to this histopathology, which is your standard lab exams, and you have different kinds of stains and things like that. And because stains don't give you the kind of answer that you need, you now have immunohistochemistry, where you add immunology to pathology. A thing called immunohistochemistry, and that characterizes tumors much better than pathology alone. And then you have molecular biology. This is the hotshot topic in medicine today, particularly cancer medicine, where you have plenty of tumor markers and another offshoot of it for treatment called targeted therapy. So these are all the kind of complex tests that we do. And whatever tests you do, you will find that medicine being accurate is a bit of a myth. I can't say it's a complete myth. It's largely so. Medicine is accurate largely in about 90 to 95%, maybe definitely 90% of cases. Doctors do know what they're doing. I can assure you on that. But in about 5 to 10%, it is very difficult to know exactly what's happening. Patients expect us to give them real answers and very, very clear-cut indications, but it really is not possible even if you want to. And so you end up with a working diagnosis. Working diagnosis. It is a euphemism for us to tell you, well, that's what I think it is, but I'm not sure. Now, as a doctor, if I tell you that, particularly if you're in an emergency department, you come with an acute abdominal pain, it's a thing that we see every day. The patient comes with an abdominal pain, acute pain, and I go and examine him, and then I tell him, yeah, it's acute appendicitis, you need an operation. Then he says, are you sure, doctor? It's a very simple, it's an operation, it hits him like a bolt from the blue. It costs money, there's a risk of an operation, it's not easy. I understand this, where he comes from, I understand what his problem is. But actually, if I'm a very, very truthful person, which I am, I can only tell him, I'm sure 96% of the time. After all the tests, including CT scan, I tell you, that is the whole thrust of today's talk. After everything, we can only be 96, 98% certain. There is no 100% in medicine. Even today, with all these complex, expensive tests, there is no 100%. And so we have a working diagnosis. And this is where the problem comes. So we tell them, yeah, I think you're acute appendicitis. And let me wait until tomorrow and see what I can do. Or if it's very bad, no, I can't wait until tomorrow, I have to operate today. There's again art there. There is no sign, there is no rule. And then he says, look, you are saying that you can wait till tomorrow, but the other guy who said it had to be done in the next half an hour. Where is the logic? That kind of differences in opinion is a part of life. And I don't think there's any controversy in either of them. That's a part of life. And this was, in fact, very well articulated by William Osler. I keep giving you quotations from William Osler. He's a Canadian physician who, in fact, came to Baltimore and set up the Johns Hopkins system in early 1900s, late 1800s and early 1900s. A brilliant physician. His contemporary was an equally brilliant surgeon called William Halsted. The two of them set up the whole concept of training as we know it today. They sowed the seeds of proper surgical residency training in America. This guy is an extremely erudite gentleman, very good with his words. And he said this, medicine is a science of uncertainty and an art of probability. And it holds good even today. Absolutely no two ways about that. And so, what we have to understand is to start with what is normal and what is abnormal. That's such a simple question that we have to address. But then you will find that everything that is in medicine, whatever you say, your height, your weight, your hemoglobin, follows this normal distribution curve. It's called the bell-shaped curve. Gaussian curve is another name for it. And what it means is that if you take a population into a study, many of you will probably know this better than me. I'm not a great statistician, but I put it in layman's terms because as far as statistics is concerned, I'm a layman. I'm a layperson as far as statistics is concerned. You'll find that there's a mean, right? There is a mean. Put a couple of clips on it, and the job is done. And in the easiest of gallbladders that one can do, you can finish it in 15-20 minutes. And if you have a lot of additions, if you find that the anatomy is not as clear as one would like it to be, it may take an hour and a half. The longest one that I have had to work on is about 3 hours to get a gallbladder out. But then, this is a similar gallbladder in another patient. You probably appreciate this, that this doesn't look clear at all. Sorry? You'll find that it's not a sac-like structure that we saw. This is a little nubbing of a tissue. It's like a little thimble or a thumb. It's sitting there. And you'll find that in the previous picture I had sort of caught it nicely and pulled it away from the liver. Here I can't pull it away at all. It is stuck there. And you have another structure sitting here. This is the intestine. This is the beginning of the small intestine called the duodenum, which is completely stuck to this structure. And I'm sure you can see very clearly that the anatomy or the structures that you're seeing there are nowhere near the way you want it to be. So we're struggling very slowly because we do not want to damage the surrounding structures. Very, very gingerly we try and separate it and see if we can find the same area of the cystic duct and the artery that we need to see to define it. And in actually as it happened in this case, we never could do it. We found that in spite of trying for quite some time, we were not getting the kind of anatomical definition that we should have for safe surgery. And so we converted it. Conversion means that we give up doing laparoscopy, go back to the conventional method, cut open and do what is required. Because in conventional method, you have a lot more space and a lot more kind of facility to do what you want to do. Now, the reason I gave you this longish story for these two, straightforward gallbladder and a difficult gallbladder, was to tell you that pre-operatively, when we recommend laparoscopy, we always tell them there's a 2 to 3% chance that I'm going to cut you open. We tell them you convert it. We take a consent form for that. And very naturally and very correctly, patients ask us, don't you have some way of knowing whether you will succeed laparoscopically or not? It's a very important thing. Basically because laparoscopy involves use of technology, your costs are going to go up. Because you're using machinery, your costs are going to go up. And when you do the laparoscopic surgery and if you fail in laparoscopy and you cut open, the hospital is not going to refund you your laparoscopic charges. You've used it anyway. You've used the machine for 2 hours. Whether you succeed or not, you're going to be charged for the laparoscopic instruments. And quite correctly, the patient will ask, I gave you more money, you spent more time, and then you still cut me up. Is it fair? And that is the way life is. And so we would like to know, if possible, accurately, when I say accurately, 100% accurately, whether we will succeed laparoscopically or not, but we haven't met that yet. There are any number of papers where several factors like ultrasound, CT scans, and several things have been met, have been studied. And in no test or a combination of tests can you clearly say whether you will succeed laparoscopically or not. So apart from a limitation in diagnosis, there's also a limitation in what we can promise you about what we do, as far as laparoscopy is concerned. And so it simply boils down to this: in medicine, 2 plus 2 is not 4. It can be 5, it can be 3, and we just have to accept that. I must tell you a very interesting story. A very senior surgeon once called me in the middle of an operation, and said, I want you to come and see this patient and give your opinion. I'm not going to tell you anything about what's happening. I want you to come with a very clear, open mind. Okay? And then I went into the operation theatre, changed, scrubbed, and then asked him, what do you want me to do? He said, feel into this person's pelvis. Pelvis is the lowest part of the body where the rectum, the uterus and all the ovaries, those structures are located. And then I looked at the pelvis, I looked at everything and said, it looks normal. Okay? It looks normal. Then he said, I want you to look at the CT scan that's put up there on the wall. Every operation theatre has an X-ray view box. And we went there and looked it up. And there was a mass or a tumor as was shown on the CT scan. And what had happened was that this surgeon had opened the patient looking for that mass, wanting to remove it, and once he has opened it, he doesn't find anything. So the first thought that came to my mind was, did they switch the patient's X-rays? Is it the correct patient's X-ray? You have a tumor sitting there, very obvious, and there is no mass on the table. Is that the correct X-ray? It was the correct X-ray. Then we said, what else could be the reason for it? It could be as strange as a fecal loading. If you have a lot of feces sitting in the rectum, for example, it may look like a mass. Was it that? Or that at that point in time, was there a fecal loading of the colon? It didn't look like that. And we looked at several, 3 or 4 other possibilities. Honestly, at the end of the day, neither of us could, conclude as to why this impression came. We discussed it with many radiologists, and we really couldn't detect anything at all. And so this patient, with my concurrence and my inputs, along with his, we closed the abdomen and came out. In that sense, in spite of all the good intentions, we have done an unnecessary operation on a patient. But you look at it the other way, and the patient had come to you with some symptoms, you've done all these tests, and you ignore this mass. CT scan says there's a mass, and you ignore it and not operate. What have you done? You might be missing. So this is a very rare situation, and I must say that in 25 years, this is the first time and the last time so far that I've had a situation like that. But there can be a limitation. That is the point I'm trying to make. The next situation that we face is just like diagnosis of gallstones and success rate in laparoscopy. You have a similar situation with open operation also. When you have a cancer, for example, when we do a diagnosis, not only do we diagnose with X-rays and biopsies and all that, we also look at what is called operability, which tells you there are a few features, I won't go into the details of it, which will tell you whether a particular tumor can be taken out or not at operation. If it is spread a lot, if it has sort of gone and involved a lot of important structures in the neighboring area, then you may not be able to take it out. And so there are other methods. You give them chemotherapy first, radiotherapy first, and then operate 2 months later. There are various other things that we have to do. But before we subject a patient to surgery, not only do we make sure that there is a mass, but we also look for criteria that that particular mass is operable or it can be operated upon. Based on those strict criteria, so-called strict criteria, I had another situation where we had operated. In fact, I was asked, come in and I was asked to give a hand, after the operation had started. Then, again, my job at that time was to confirm to the primary surgeon that that tumor was indeed inoperable. He had opened the abdomen thinking it is operable based on the tests. He goes in there and he finds it is not operable, and he wants to make sure that, that's what we do. In fact, if I were in that situation, I would call another surgeon, because I don't want to think that I know everything. Maybe I'm missing something that is there. And so we always take another opinion. So on the table I went in there and I found it was inoperable. Now the tragedy for this patient started at that point and not before that point. We closed the abdomen. And this is another thing that I would like to say is very, very important, because at that point in time, the patient, the primary surgeon and myself, both of us went out of the operation theatre, told them that this was the situation and this is what we plan to do. And the reaction from the patient was one of anger and resentment and not logic. This is where science comes in. If the patient had appreciated that there is limitation in science, limitation in the way you can assess with tests, they would not have been angry with me, because not me necessarily. But they got angry. And they took their discharge against medical advice. I said, we tell them, we would like to do this. They said, no, we want to go somewhere else. You have failed us. And they went away after, as I discharged against medical advice. And unfortunately, they went to another institution where another surgeon, I'm sure he is very logical and is very scientific and very ethical, I'm not questioning any of those aspects, but he saw the same thing. He said, this is operable. This is operable. Why didn't they operate? And what happens is, this is where human nature comes in. Somehow we feel that, that we can do better than others. And that gentleman's judgment was clouded. He says, I don't know whether he even asked who the surgeon was, whether he inquired whether a second surgeon had come and said that it is inoperable. I don't know whether he did it or not. But he saw this and said, I can take it out. And he went in and took it out. But unfortunately, it was not fit to be taken out. That was the point. And the patient had so much bleeding that practically it was an on-table death. The patient died 4 hours later. Because when we saw that, we knew that this would be an unnecessarily risky operation for that patient. But then once you go only by this findings, and you lose, that is where the art of medicine kicks in, art of surgery kicks in. When you do not do that kind of introspection, take another opinion, be a little careful. If you don't do that, then you can have a big problem on your hands. Now, this is, as far as the limitations are concerned, inherent to a given test. You cannot diagnose a gallstone even when it is there. If you diagnose it, you cannot say how bad the gallbladder is. If you have a tumor, you can diagnose it, but you're not always sure whether it is operable or not. There are uncertainties. But then we come to the concept of false positive and false negative results. Okay, are you with me till now? Any questions, doubts, or comments? Anything else? That's what comes now, sir. Yeah. Okay? So, what we're trying to do, that's right, that's what we're trying to talk about. False positive is a test result that the test indicates that a person has a particular disease, and he actually does not have it. Right? It's quite possible. Like every test that we do, common examples that we have is this: HIV, tuberculosis, cancer. You go and get yourself tested for HIV, and one test, a common test that we do, ELISA we call it, the kit says you're positive. It will be devastating to the person, obviously, and we know, the world may not know, you may not know, but we all know, our doctors know, that one test being positive is largely correct, but not 100% correct. It's not 100% correct. So what we do is, the WHO standard today is that if you are positive on one test for HIV, you have to do 2 more different kits, 2 different kinds of kits. And if all 3 are positive, then you're positive. That is the kind of rule that we follow. So if you have a false positive test for any of these diseases, it could be even dengue, it could be typhoid, whatever disease it is, there is a possibility that the test may be false positive. Okay? And that is devastating, as you can see. It can be devastating when you're wrongly labeled with a disease that you do not have. And so what do we do about that? So we do different types of tests for the same disease. I told you about HIV already. We do what's called an ELISA, we do what's called a radioimmunoassay, we do what's called a PCR, polymerase chain reaction. There are completely different classes of tests. We do all those on the same disease, and only when you have that disease, only when you have positive in all these, or the majority of these, then we say you have the disease. Understand that when we have to do all this, there are 2 things that happen. You will be spending more money, and you can't be angry about that. And number 2, you will be spending a lot of time. Some of these tests take a week or 2 weeks for the report to come. But then those 2 weeks, I know, are extremely anxious and troubled times for you. You want it tomorrow, you want it in the next hour, but you can't do it. That is a limitation. And that is the way, this is the thrust of this talk, as you can say. I would like you to, as persons, understand that there are limitations. And so you need to have a scientific, logical outlook to what these tests can offer you. Implement several criteria for diagnosis. That's another important thing. When you take up, I'll give you a story a little later of a lady who went into great difficulty because of this. Now, suppose you want to diagnose cancer in somebody. If you have there are several criteria that we use to say this is cancer. The nuclear characteristics, the way the cell looks, and the number of divisions, mitotic figures that you have, and there are several more. And you've got to put all of them together and then interpret that it is there. If you look at only one of them, just the nuclear features, for example, or just the number of mitotic figures, then your false positive rate will be very much higher. Check with different observers. This is, sorry, sorry about that. Yeah. Check with different observers. This is a very common thing that we do. And it's very few patients understand this. So when you get a report, it's very common for me to go and show it to another person. Show it to another surgeon if it's a surgical issue. Show it to another X-ray, a radiologist if it's a radiology issue. And keep our pathologist sends it to somebody else. And before they give the report. And it's a routine thing because that way we even without subjecting you to the expense of another opinion, subjecting the patient, you already have the advantage of a second opinion. That happens very, very often. Always collaborate with other cases. As we said, when I was giving you the example of that lady with the gallstone which did not show on X-ray, on the ultrasound, we collaborate an ultrasound with the liver function test, which is a biochemical test, a different kind of test. Collaborate with MRI, magnetic resonance imaging, which is a different kind of test. So if you do all this, we minimize false positives. And this is the story of a lady who got into real trouble because she went with features of possible rectal cancer. Alright, she had bleeding, she had pain, and the surgeon quite correctly did the sigmoidoscopy, and this was the picture of that patient. This looks like an ulcer. It's a little different from the lump that you saw earlier, but cancers can look like ulcers. They look like wounds in the rectum. This was biopsy. Alright? Now, it can be cancer, it can be also a benign condition called SRUS, solitary rectal ulcer syndrome. Okay? It's very common, and SRUS does not need an operation, it is not a cancer, it is not life-threatening. Okay? It just settles by itself and it takes a long time to settle. That's what SRUS is. The surgeon thought that this was SRUS, but he can't just leave it like that, he has to prove that it is SRUS. So he took a biopsy, and to his surprise, it was reported as a cancer. It surprised him. And so he did the logical thing and sent it to another teaching hospital. It's a big center, you find professors and a lot of people, a lot of big brains in a teaching hospital institution working there, and they reported it as a cancer. Alright? And so he went ahead and did a cancer operation. And for the patient's ill luck, again operations are largely successful. But about 5 to 10%, 5 to 8% will have problems. So he had taken out the cancer and put the two ends of the bowel together. And in about 5% of cases, the joint that we make does not heal. So it leaks. And then they're in trouble, they need another operation, they get into ICU. It costs lakhs of rupees to bring them out of that, and then it takes about a month to get better and all that. Unfortunately, that happened to this patient. Alright, so she had to have a second operation, 7 days after the first operation, ended up with a colostomy where the motion comes out into the abdomen, comes into your bag, because the motion could not go through the normal way because there was a leak there was a hole where the joint was made, had a large bill, and the patient is all getting ready to sue the surgeon for doing what he did. The reason they took out this part of the diseased bubble, which was called cancerous by two pathologists previously, sent it for tests as a routine after the surgery, and it came back as benign. They said there's no cancer in it. This SRUS is not cancer at all. So the patient, quite rightly, is now asking, you did an unnecessarily big operation on a disease that did not need an operation. And then you gave me a complication, of course. That's the way patients say, but the surgeon didn't want to have a patient, doesn't want anybody to have a complication. What happened? So you gave me a complication, gave me a big bill, and now you tell me I have no cancer. Okay? Next scene, consumer court or whatever court. This is really very ironical because nobody is at fault here. I cannot fault the patient for that line of thinking. I cannot fault the patient, the surgeon for what he did. If you can fault anybody at all, it must be the pathologist who called it cancerous when it was not cancerous. But then he has his limitations, in the sense that even if we know, and it's not one pathologist, two pathologists called it cancer. And the real culprit here is nature, or God, or whatever you call it. Because he leaves this 5 or 10% of confusion in everything that we do. And there is really, nothing one can do about it. Except again, keep doing things. So that's the concept. That was an example of a false positive case, when you call something cancerous when it was not cancerous. And equally dangerous can be a situation when it's false negative. A test result tells you that you do not have a disease when actually you have it. You miss the diagnosis. Right? Okay? Same thing. Suppose you have, and this is in fact my own patient, and I'm actually going through this difficulty myself. This was a very young lady who came to us with a neck swelling. And it's not the same patient, I gave an example of some other patient, but the swelling that comes up here. And the physician saw the patient, had the commonest diagnosis in this country when you have a swelling like this is tuberculosis. Okay, so what we did was to take that lump out to prove that. I did a very small operation, took that lump out and sent for tests. The report came as tuberculosis. Alright, so my job is actually over. My job is only to take out that lump. The physician then treated the patient for tuberculosis. Lo and behold, after an initial improvement in the features of 15 days, initial 15 days, the patient actually had more discomfort, more fever, and was looking more ill. So the physician rightly thought, okay, we need to watch you. Please come back in 2 weeks and see what happens. Normally once you put them on, they're fine, you come back in a month, we say, but this guy was careful. He brought her back in 2 weeks' time. The patient was slightly better, but not very much better. Okay, come back another 2 more weeks. So this went on for 2 months. But the patient was not showing the kind of improvement that you would expect if it were tuberculosis. Remember, it's biopsy proven. Biopsy proof is considered gold standard in medicine today. Biopsy proven, the patient did not get better. And by this time, we found that she had more lumps elsewhere. She had a lump in the abdomen, she had a lump somewhere else. And then at that point in time, the physician asked me to see the patient again. And when we saw together, we decided we must do more tests, got CT scans and this and that. And to cut a long story short, we found that the patient had a lot of disease in the abdomen. Where it had started in the neck, there was a lot of disease in the abdomen. And we knew, and the patient had good compliance, She had taken all the treatment that we had given. What happens is, many people, we give them anti-tuberculosis treatment, they may not take it at all. It gives them some nausea, vomiting, some little jaundice sometimes. Sometimes they throw it away, they don't take it without understanding the implications. So we made sure that there was compliance, that means the patient was taking these medicines correctly. Then it has not worked. Why hasn't it worked? It's some other disease. And what could that some other disease be? It's a disease called lymphoma. It's a cancer. And so we had to go in, because the whole of the, by that time within that 2 months it was an aggressive tumor. The whole of the spleen was replaced by this tumor. So we took out the spleen, we took out more biopsies, thinking this is lymphoma, this is not tuberculosis, we have to take it out. And when we did that, and I must add that when the CT of the abdomen was done, he had called it tuberculous abscess of the spleen. He called it tuberculosis of the spleen on X-ray. But he said, no, we can't swallow that diagnosis. So we took it up and took everything out. And you won't believe this, and this is not an exaggeration, the first 3 pathologists whom we sent it to called it tuberculosis. First 3 pathologists whom we sent it to called it tuberculosis. And we just couldn't accept it because we had the clinical acumen or the clinical advantage of seeing that this patient has not responded to treatment. So we sent it for a 4th opinion, which must be very unusual. I have never had so many opinions on my patients until this case. And that confirmed that it's wrong. Okay, at the end of 2 months and 4 opinions, we got a diagnosis of a lymphoma, of a cancer. And we treated that patient with cancer, and the patient is improving. But that had made the father of this patient so angry that he went to court against us. And the lower court, you won't believe it, gave a judgment against us and said, on your clinical grounds, on the suspicion, we told them we had suspicion of this, we kept on trying, we couldn't get it on the fourth opinion, we got it, that's why we did it. The judge says, if you had a suspicion, you should have treated her for cancer. It's your responsibility. Unfortunately, it's completely wrong to say that. Completely wrong to say that because there's another case in the consumer court which went against the doctor because he gave cancer treatment on a suspicion of pathology, cancer raised by the pathologist. He had done the very same thing. He had the treatment, the clinical behavior of the tumor was very aggressive. So he had done the operation and the pathologist says suspicious of malignancy. But the doctor was so sure that it is malignant because the way it behaved. He gave chemotherapy and because he gave chemotherapy, the patient had some problems and then, judgment went against him. So what happens is that we have been found guilty of something for sticking to some rule, and the same rule when it was, the other doctor had followed that the way the judge had asked us, expected us to follow, he is also found guilty. Right? This is the opposite, it's the same thing that has happened. And I'm not even blaming the judge or the system, it is the lack of understanding that there are limitations in what we can provide in medicine that is causing it. There are really no negligent, bad people in the whole game. I'm sure the patient has gone through difficulty, the doctor has tried his best, the judge is doing his job. But then we have to at some stage understand, that's why when HR asked me to say, please, I could talk about any number of things about laparoscopic surgery, cancer, this, that. But I wanted to give this to a general forum like this, because this is what we have to understand. This is what we have to understand. There must be a debate and a movement among the public to understand and analyze how doctors work and where the problems are, so that you understand and see the so-called mistakes in a different light. Because if you see the papers today, every other day there is something about some negligence and some malpractice done by some doctor. What they do not realize, what people do not realize is that reflects 5% of the cases that can come to the consumer court. 95% of cases are thrown away in the sense that there is no negligence found. But the 5% that you have, that is highlighted. And that is something we have to have some perspective on. And as I said, confusion prevails where, to know what exactly is considered gold standard, because even the gold standard has a degree of uncertainty to it. Now, how do we minimize false negatives? You consider clinical behavior. How does if something is going very far, it must be cancerous. But then, it is subjective. What is fast? How do you define fast? That's subjective. It takes time. And one of the big problems in the case I quoted was that we waited 2 months. You can't decide before that. I cannot decide the medicine is not working within 2 weeks because we know that it takes at least 4 to 6 weeks for anti-TB drugs to take effect. It takes 4 to 6 weeks. I can't do it before that. Take more opinions, which you always do. But then the downside is this. You take 3 opinions and 3 people tell you 3 different things. It's not at all unusual to happen. What do? You're still back at square one, more confused, perhaps more desperate, because you don't get the same opinion. And corroborate with different tests. Yes, instead of ultrasound, we can always routinely get CT scan. That will cost another 8,000 rupees more. You can get an MRI that costs another 10,000 rupees more. Get a PET CT, it costs 20,000 rupees more. You can always do tests. But then today, healthcare workers are saying, look, you've got all these expensive machines installed in your hospital, and so you're getting all these things to make them work and make money. That is the problem. And in fact, America has gone through this like mad. The healthcare cost in the United States is very high, and it is high because they keep doing tests. And they keep doing tests because they're afraid they're being sued. That they'll be sued. That is the real problem that faces healthcare today. And so we come to the concept of, when you have false positives and false negatives, the next few slides are a little heavy, and so I'm going to skip through them. I want you to only understand the principles and not the actual calculations. We look at what is called sensitivity and specificity of tests. Alright, this is what it is. You have a particular pathology, a particular disease. For a given test, there is a degree of false negativity and a degree of true positivity. And when the disease is absent, for example, there is a degree of false positivity and true negativity. As you can see, normally the large majority will be true. That means that the majority of times when the disease is present, the test will say it's positive. When the disease is absent, it will say it's negative. The false negative or the false positive will be a minority. That is something we should take heart from. We don't have to be desperate about that. And there's a formula, you don't have to remember this. There's a formula to detect that. And so, based on sensitivity and predictance and specificity, you have a concept of prediction. Right? That's an important thing. You want to know when you do a test. As a patient, you want to know, you want this given test. How accurate is it? How do you describe accuracy of a test? The accuracy is based on predictive value. Positive predictive value, negative predictive value. I won't go into the details, but I want you to understand the concept of true positive, false negative, false positive, and true negative. This is a grid of 4 squares that we use to calculate these predictive values. It is self-explanatory. People with disease testing positive is true positive. People with disease testing negative is false negative. People without disease testing positive is false positive. People without disease testing negative is true negative. These are the 4 grids that we have, and you can see that there is a formula to correct each of these. Sensitivity, specificity. So you have, say a test is 60% sensitive and 70% specific. That's a very limited value of the test. You want a test to be 100% specific, 100% sensitive. Such a thing doesn't exist. So if you have something around 90%, 95%, you are happy. So when you calculate the sensitivity and say it is 90% specific, that's good enough. And if a 90% specific test says that you don't have a disease, then you don't have a disease. Accept that. That's the kind of logic that we apply. Positive predictive value, look at this. Many tests have positive predictive value of only 50, 60, 70%. That means if a test tells you that you have a gallstone, if PPV, positive predictive value, is maybe only 70%. So you want more corroboration with that. You would like a positive predictive value of 90%. The negative predictive value, it should be as close to 100 as possible. Negative predictive value tells you that you do not have a particular disease. Come to me with fever, I do a test for dengue. We all know about dengue and how dangerous it is. A given test must give me a negative value which tells you that you don't have dengue, and it must have a negative predictive value of 90%, 95%. If you anything less than that, that's not very valuable. What do? Do another test. Maybe repeat it a little later. Things like that. Take another opinion, go to another lab. Or something like that has to be done. And as I said again, the downside of this is time, money, and anxiety. But that is something which we have to spend. And so, we come back to Osler and tell you what he has been telling us in the late 1800s. What is the student but a lover quoting a fickle mistress whoever eludes his grasp? And this is this lot with doctors. From the time you are a student to the time you retire, until you retire, you're really grappling with something that you're not very sure of. And variability is the law of life. Just like no 2 faces are the same and no 2 bodies are the same. We are trying to apply the results of a given test to a very variable, complex phenomenon called a human being. And so we have to understand that under these conditions, what we understand of a disease is actually limited. Even though in a large majority of cases we know what we're doing, in a minority of cases we really do not know what we're doing. And we all need to be aware of this. All of us, the patients, the doctors, the hospitals, the guys who do the tests. And our endeavor is to keep improving the situation so that we one day, hopefully, reach a 100% level. But then if I say this, it might fill you with a lot of desperation that, next time you go to a doctor, you think the doctor knows nothing, he's just talking to his facts. And that's not true either. You've got to see things in a proper perspective. It really is not that bad. Uncertainties are there. Majority of the times we do mean what we say and we do get it right. But then the problem that I always face is, as I said, somebody comes and says, I think you have appendicitis. Are you sure? He says, and I truthfully say I'm 98% sure. I'm not 100% sure. My appeal to all of you is that when I say that please, and some people think I'm being sarcastic, I'm being arrogant. I'm not. I want you to understand that that is the real truth and nothing but the truth. And take it from there. And the second thing that happens to us is that when you do an operation, for example, you must understand a little bit of percentages, and that's where perspective comes in. And you do this, I quoted that story of the lady who had the operation for the cancer rectum, who had a complication. I told you that the complication rate is 5%. Okay? So 95, if I did 100 such operations, 95 of those 100 people will go home comfortably with no problem. Go home in 5 days, 7 days. 5 of them will have this problem. And then they have to spend a lot of money, their life is in danger, they have to be in ICU, they take a month before they go home. But the problem for me is that before I do the operation, I do the same operation. It's nothing different in different people. I do not know which group they belong to. Whether they are in that 5% minority group or the 95% majority group. So I just quote them, this is the statistics. It is also true that just like complications, we talk about mortality of 1%. In this same operation, mortality of 1%, which means that if I did 100 such operations, 1% will die of the complications of the operation. 99 people will go home without any problems. But then I don't know which one it is. For the person, that 1% who dies, it is 100% death. Right is gone. You know, there's nothing I can do about it. And this is the kind of uncertainty that doctors have. And then what happens when for every operation that I do, I quote these things, you know, mortality, morbidity, the complication rate, the risk of death, and all these things we quote. And the large majority of patients don't understand. You know, I don't blame them. They don't understand what this is. And then after I explain everything to them, they ask me a very simple question which completely floors me. Ella paragilla alva doctor. What paragilla? I don't know. But if I knew, I would say paragilla. But paragilla. Paragirodrindane idella heltarodu nanu ninge. There is a risk involved, there are issues involved, kindly understand. And it's something, I don't blame the patients, it's difficult for people to understand. It's difficult for them to understand the risks involved and things like that. We come to the mother of all tests, you know, and this is called the PET CT. It is the fashion of the day today, and I'll finish in the next 5-7 minutes. The reason I put this up last was that it is considered wrongly that it is a great test and it will give you all the answers. If you have a cancer anywhere in the body today, whatever happens, the first thing the doctor tells you is go and get a PET CT. Right? It's 22,000 rupees it's cost. Very expensive. You can finish many operations with that money. Right? But then one test costs that much. And we do this, and you find that that can be as confusing as not doing it. It's true. And I'll give you, I don't know if I have that story in the next slide. Yes. I'll give you this story which was to me a very humbling experience in life, because it involved my friend and surgeon colleague. He was the patient. Very educated, 1 year my junior, my colleague, my friend for many years, and this happened to him. This gentleman, and surgeon himself, had a little bit of pain in the upper abdomen. His first thought was that he must have some kind of a gallstone or something like that. Went and, took some painkillers for 2 days, and then afterwards got a scan done, and they said, radiologist, very accomplished radiologist and a friend, remember, the patient is a surgeon himself. And so it puts things in perspective for you, how vulnerable we all are. That's the message of this little story. Got an ultrasound done, and they said, I think it's an abscess is involved. I think there's an infection that's going on in your liver. They said. And said it's not liquid yet. Wait for standard procedure. Wait for 2 to 3 days, it will liquefy, and then I put a needle into it. So the surgeon took antibiotics for 3-4 days, and then a week after he got the pain, or 10 days after he got the pain, he called me and said, look, I'm going to the radiologist, he's going to put a needle. I'll be happy if you can come and stand next to me. It would be nice if you can be next to me. So I went to the radiology suite along with the patient and of course a very good ultrasonologist who put the scanner and ultrasound scan on it and said, look, I don't find liquid here. And that's when our antenna went up. At the end of 7 or 10 days, If it's an abscess, it will be liquid. And ultrasound is very accurate in detecting whether it is liquid or solid. That's where you have very little confusion. So I said, don't put a needle into it. We need to learn a little bit more about it. And said, get a CT scan. CT will tell you what it is. And so instead of doing that so-called ultrasound guided aspiration, in the same sitting we got a CT done. And lo and behold, it was a tumor. It's a tumor. And tumors in that area can be devastating. And so the very next day, he was on the operating table. I was trying to learn more about that tumor, and so we did a laparoscopy. Because he's my colleague, I had another 2 surgeons standing next to me. Sometimes it makes things more difficult. But anyway, I had, all of us, we were all very concerned about our good friend. So we did a laparoscopy, took some biopsies. The purpose was not to remove the tumor, but to get a diagnosis. We did that. Then we took a biopsy, and 2 days later it proved to be cancer. So in comes the PET CT. You need to know whether it's gone somewhere else or whether you can take this tumor out or not. If the tumor is confined to the liver, we can take it out. If it's gone beyond elsewhere in the body, it's beyond the redemption as it were. And so we got a PET CT done. The PET CT said, I find hot spots in the chest, which means it's gone in the chest. And you could see visibly my friend completely getting depressed within a few hours of this. He said, look, I thought, remember the whole thing in a surgeon, history of 1 week, and not more. And then he got terribly depressed. I told him, look, I've read up about PET CT, you keep reading about it all the time. I don't think it is the end of the world for you. Alright? I don't believe that just because it's a hot spot on CT that it is a cancer. Let's be optimistic. All surgeons are optimists. We're always, we are optimists. Otherwise you wouldn't touch a patient, you wouldn't cut a patient. Before you cut somebody, if you think you're going to fail, how will you cut anybody? So our mindsets are that we're going to succeed. So we said, let's go and check it again and had a CT-guided biopsy. That area where it showed was a hot spot. We got a CT, went into that, took a needle and took some tissues out. And we proved that it was not a cancer there. And that CT detected spread was in fact a fallacy. We proved that. And so his mood improved. I can now try and take this tumor out and see what I can do. So he went to Chennai to have his tumor taken out by one of the recognized experts in the field, but unfortunately he succumbed to the complications of the operation. You can imagine the problem. You think it is an ultrasound says it's an abscess, it's not an abscess. There is CT, do think it's a cancer, and then you say it's spread, it's not spread. It is not spread, and so you try and take it out. And good centers, and this one indeed was a very good center and a very good surgeon. The risk to life of somebody for this operation is 5%. This mortality is 5%. And my friend happened to be in that 5%. Unfortunately, God or nature, whatever you say, did not put him in that 95% group who survived. God or nature, as they keep saying it, put him in the 5% mortality group and he died at 55 or 56 years of age. And so this is the kind of limitations that we have in what we do, and we are no exceptions. I'm a human being, a doctor is a human being like anybody else, and if I go to a test tomorrow, if I fall ill and I get a test, all these go through my mind. The only difference is because I know all this and I've shared it with you and I hope you understand and believe what I say, then my mind is at rest. I'm not worried. This is the best we have so far. Life is going on. As one of my patients told me one number bandre okay sir nano. So if my number comes up, I'm going to go. That doesn't matter. Let us live comfortably for as long as we are, without too much rancor and without blaming people. Without blaming people. That is my thrust for today's talk. And how do we cope with this? We have proved, I think, I've stretched it like chewing gum and told you several stories and several things where, we're not sure of what we're doing. That's true. What do we do? As doctors, I think, and this is open to debate and comments from you after the talk, we must accept limitations. We explain this to the patient. Now, most patients want you to put your hand on the shoulder and say, no surgeon can do that. If you're doing it, it is drama. Nothing more than that. You can do a good job, but then rest is left to fate. Rest is left to fate. So you must explain the limitation of this patient. Keep an open mind and invite opinions. I invite opinions from patients, by other surgeons, other doctors. If you are not comfortable, no. The whole exercise is to make sure that we are all comfortable mentally about what we are doing. decision to operate, decision to do this, decision to do that, all is a joint decision. And so let us keep ourselves comfortable. Be watchful, think of various things. I teach postgraduates, and the first thing I keep telling them, I criticize them, is that they do not entertain what is called differential diagnosis. You do an endoscopy, you see an ulcer, you think it's benign. Then I ask him, don't take it as benign just because you think it's benign. What else is it? What is the differential diagnosis? What else can it be? Always keep entertaining that thing, that's being watchful. And repeat tests if needed. What you see today may not be seen 3 months later, or what you do not see today may be seen 3 months later. And this is a very common thing that happens. Somebody comes to me with a pain in the abdomen, I do some tests, they're all negative, I tell him everything is fine, and I send him away. 3 weeks, 4 weeks later, he gets the pain again, he says, Lakshman didn't diagnose me, he wasn't right, let me go to somebody else. Go to Y. And Y sees that and the diagnosis is obvious. And look, Lakshman missed this, why diagnose it, this fellow is useless. And it's very common for people to think that. But then what happens is that the same thing happens to Y. Some other patient has gone to Y 4 weeks previously. Okay? And he would have missed something because it's not obvious. And then he comes to Lakshman. And then I diagnose it, and then the patient thinks, Lakshman is so good, Y was so bad. In fact, nobody is good, nobody is bad. This is a limitation of that process where repeat tests will tell you what you need to know. And as patients and relatives, what do? Be patient. Give doctors time and space. Allow them, they want answers immediately. In spite of all these things, it's difficult to get the diagnosis that quickly. And do not shop around. This is what I keep saying. Going from Dr. A to B to C to D in search of something that is probably not there. It's going to harm you. I have no doubt about it. A good doctor, I always say, himself will ask for another opinion. If I don't know what's happening to my patient, I'm the first one to ask for another person's involvement. So that at the end of the day, we all want the patient to get better. And understand that failure is not negligence. This to me is my main thrust for the evening. I may not diagnose a particular condition. It's a failure. I may not, having diagnosed, I may not cure a condition. But that is not negligence. Negligence must involve willful, knowingly you do not do something that you should do or do something that you should not do. Errors of omission and commission. Knowingly doing it is negligence. And everything else, I think doctor deserves space. That's what I call space. And thank you very much for your patience here.